Good evening, Dr. Lewis and Dr. Garber. I am glad to share my project presentation with you. And again, I apologize for this cold that I've had for ever. It feels like not really just a few days, but my voice isn't what it normally is, and I apologize if I'm gasping for air. But I'll go ahead and get started, and I want to share with you my presentation on measuring levels of preparation for decision making and patient satisfaction in a breast cancer support group. I have been facilitator of this breast cancer support group for at least 18 years. It's been a pleasure. I take great pride in how I've been able to help these people, but I have to tell you, over all of this time, sometimes I think it's really them who help me. I'd like to acknowledge Dr. Erica Lewis, who was a fabulous project chair. She has strong shoulders and compassionate ears and a lot of patience for needy doctoral students like myself. I'd like to acknowledge Dr. Christina Blyer, who was a fabulous preceptor who I just lucked into by virtue of Dr. Sharon Zook. Thank you, Dr. Zook, who introduced me to Christina. I also want to give a shout out and acknowledge Dr. Zook and Dr. Garber for being really the first two interim project chairs for me in this endeavor, and until I finally landed upon Erica or Dr. Lewis, but I've really enjoyed getting to know all of them well. I'll start off my talk by introducing the topic of breast cancer. Breast cancer is an archaic health problem, first illustrated and documented by the Egyptians in 3000 BC, so this is your history lesson. There are actually four evolutionary periods of breast cancer. The first was this, which was the empiric period where they did the first surgeries. The next was the pessimistic period, and I see why it was called this, because they tried to pour milk and salicylic acid and do more holistic treatments on breast tumors to try to treat them. The next was the optimistic period, where surgery was actually first initiated with a radical mastectomy, and now here we are from 1960 moving forward with the realistic period, which I think that's a great word. It talks about the technological advances we've made, the biological genetic advances we've made, and really establishing more of a cure rate moving forward. And interestingly, just about 2 weeks ago, a gentleman named Bernie Fisher, who was a physician, a surgeon, who actually came up with the simple mastectomy and lumpectomy as an alternative to the radical mastectomy. He also came up with the advent of hormonal therapy. Sadly, he died, but he was 94. But I think about what a contribution he made to this field. Any conversation about the diagnosis of breast cancer was really hard until the formation of the American Society of Cancer Control, which evolved into the American Cancer Society. And this really established a platform for the development of cancer support groups. Civic conversation about cancer reached an acceptable level finally through Betty Ford's candid revelations about her diagnosis in 1974. She was a real pioneer, very brave woman who went out into the fray and talked about it publicly in the media, and it really gave the media license then to talk about it in a great and acceptable way. And another kind of fun fact was about 10 plus years ago, I had Susan Ford Ronick to do a lecture on breast cancer and her talk about her mom, and we got to have dinner, just the two of us, at the Hotel Ronick, and that was a really great experience. She was a very interesting person to get to know, and interestingly, she actually is a mystery novel writer. But just a fun fact. Breast cancer is the second most diagnosed cancer in women, second to skin cancer, and that 1 in 8 women will be diagnosed with breast cancer within their lifetime. The death rate has declined to 1.3% from 1.9% from 2011 to 2017. And there are greater than 10 different pathological diagnoses of breast cancer. Different types of breast cancers require different treatment modalities. So you can see that there are lots of different treatment modalities recommended. Early detection of breast cancer is directly related to patient prognosis. So I'll get up on my soapbox here and say everybody in this room who is gender appropriate, age appropriate, starting at 40 should be getting their mammogram annually, and keep getting them till they can't walk to the mammography center or roll to the mammography center anymore. A diagnosis of breast cancer actually requires a lot of decision making about treatment choices, what surgeries to have, chemo, radiation, hormonal therapy, genetic testing, reconstruction, just so many different choices to make. And consequences of treatment decision-making can often raise internal conflict and cause stress among all the women who are diagnosed. So therefore, women often include multiple other sources in their pursuit of treatment decision-making, including family and friends. But many women choose to attend breast cancer support groups for emotional and social support. But by attending multiple support group meetings, women can hear about the other various treatment choices women have made and why they've made those, and also hear about others' experiences gained from these treatment choices. Support groups involve recurring face-to-face meetings of survivors who share a common diagnosis of cancer. This support group, a breast cancer support group, really provides structure for women to seek out tangible, emotional, social, and informational support about their treatments. Support groups happen during various phases of illness and share 4 common goals: the permission of expression of feelings, the ability to nurture mutual support of our participants in the group, to inform group participants about the illness and treatment options that have been available to them, and to improve group members' coping skills to resolve emotional conflict. Patient acquisition of health information about diagnosis and treatment options results in an increase in patient satisfaction and clinical outcomes. So therefore, patient decision-making involves reviewing all treatment options, researching the pros and cons of each option, narrowing treatment choices to pursue, and making the final treatment choice, which must be done to reach the final decision outcome. The provision of an interactive decision aid or platform can assist patients with difficult treatment decisions. Bennett et al., in a 2010 article, communicated that the use of patient decision aids is helpful in treatment decision-making because they provide options, clarify values, and add to the recommendations made by the healthcare provider. The well-validated Preparation for Decision-Making Scale, created by the Ottawa Healthcare Institute, is a decision aid used to evaluate levels for preparation for decision-making. 68 studies have mentioned or used the scale as a decision aid to help evaluate levels of preparation for decision-making. However, literature review reveals no studies using the Preparation for Decision-Making scale to evaluate or measure levels of preparation decision-making from the attendance of a breast cancer support group. Because of this lack of literature, a need arises to provide evidence to support the continuing and important need for cancer support groups. The problem for my project is, despite anecdotal local evidence and evidence in the literature to support positive outcomes for attendance of a breast cancer support group, it's problematic that there is no assessment of patients' preparation for decision-making and treatment satisfaction for the Carilion Clinic Breast Cancer Support Group. The purpose of this project was to complete an evidence-based assessment of outcomes of preparation for decision-making and treatment satisfaction based on the frequency of attendance of the Carilion Clinic Support Group. The primary aim of my study was to evaluate if patients with more frequent attendance of the Carilion Clinic Breast Cancer Support Group had increased levels of preparation for decision-making and higher satisfaction with breast cancer treatment decisions. The secondary aim was to identify other potential outcomes of group attendance. The theoretical framework I chose for this study was Donna Bedian's Theoretical Framework of Healthcare Quality. Donna Bedian's framework is composed of 3 components of structure, process, and outcome. And he defines structure as the healthcare setting and provider qualifications. He defines the process as the elements and appropriateness of care delivery and evaluation of medical error, and the outcomes as progression of illness, survival, and complications or care and illness. In particular to my study, the structure was the setting for the Carilion Breast Cancer Support Group, which was the Carilion Breast Care Center, the process of the Breast Cancer Support Group, which has already been established over these years. So we're focusing really on the outcome, which was looking at the preparation for decision-making and patient satisfactions for treatment decisions amongst the group participants. The setting was the Outpatient Diagnostic Mammography Center, Carilion Clinic Breast Diagnostic Center. The group is a bi-monthly rolling group established since 2002. Peer-to-peer discussion about unique cancer experience, diagnosed and question exchanges concerning emotional and social support and treatment decision-making happen within the group. And what makes this group most unique is that women may attend it as many or as few times as they choose. This is an evidence-based research study, which was a cross-sectional survey that was mixed method in design. And the methods I'll explain in the next couple of slides. Carilion Clinic's Health Analytics Research Team assisted in creating a REDCap survey for dissemination to 137 breast cancer support group participants who participated in the group from 2014 to 2019. The survey was disseminated this June in June 2019. A reminder email was sent to participants who had not responded to the survey 2 weeks after dissemination of the survey. Data was evaluated 1 month from the survey's initial distribution. The REDCap survey included 4 parts that were evaluated separately: the patient demographic section, the preparation for decision-making scale, the Likert type patient satisfaction decision question, the qualitative open-ended question, what else would you like to share about your support group experience and treatment decision-making. The independent variable was the frequency of attendance up to the support group, broken into 4 levels. Those levels were 1 meeting, 2 to 5 meetings, 6 to 10 meetings, and 10 plus meetings. The dependent variables were based on the preparation for decision-making score and patient satisfaction with treatment decision results. The collected data was analyzed using SAS Enterprise Guide version 711 and looked at the frequencies and percentages of the demographic information was presented in the tables. The non-parametric test, Kruskal-Wallis, was used to evaluate and to test for differences in preparation for decision-making and patient satisfaction among the 4 groups of participants based on their frequency of attendance. Qualitative data for the open-ended question was grouped by themes and used to address the secondary aim of the study. Sandalowski asserts that numbers are valuable in presenting qualitative work to establish its worth, document what is identified about the research topic, describe the study sample, and generate meaningful data. Percentages were used to evaluate the open-ended responses. This is a schematic of the preparation for decision-making scale survey so that you can take a look at some of the questions that are asked that make it a decision aid specific to the Carilion Breast Cancer Support Group. The ethical considerations that occurred during my study were that the IRB approval was obtained from Carilion Clinic and James Madison University. There was a waiver of written verification of consent implied from participant completion of the survey. There were no direct risk or ethical concerns for patients from completing the survey. We'll start off with results. The demographic results were that 90.7% of the participants responding were English speaking, 98.1% were Caucasian. The age range was 30 to 45 years was 55.6%, which was the participants who attended the group most regularly. And the access to the internet was 98.1. I thought this was a kind of an interesting statistic because everybody had to reply to an email, but one person didn't answer the question that they had internet access. So that is what made 98.1% access to the internet one of these results. The breast cancer types that were most prevalent were ductal carcinoma in situ and invasive ductal carcinoma. They are 2 of the most common types of breast cancer as well. So many of the women coming to the group had these types of diagnosis just by virtue of it being a very common type of diagnosis. However, there were certainly other breast cancer diagnoses represented among participants. The preparation for decision-making score. The Kruskal-Wallis test results indicated that there was not a statistically significant difference among the 4 groups, but that trends supported the primary aim of the study, which was great. Patients who attended 10 plus meetings had the highest preparation for decision-making scores, the mean at 4.535 with a standard deviation of 0.78. And those who attended only 1 meeting had the lowest preparation for decision-making scores, which was intuitive, we hoped, but the study actually bore out these results, which was great. The results of the patient satisfaction score, however, were statistically significant. The Kruskal-Wallis test results indicated that there was a statistically significant difference among the 4 groups of in frequency that attended the group. A post hoc analysis, the Dwas-Steele-Critchlow-Fligner method, indicated that those who attended 10+ meetings were statistically more satisfied with their overall experience than those who attended only 1 meeting. So I was really pleased with that, and you can see the nice pie chart here representing these results. The qualitative assessment results were 38 out of the 54% participants actually provided a response to the open-ended question, which was great. 34 of the 38 participants, 89.5%, claimed to gain some form of positive support from attending the support group sessions. Keywords were used in patient responses were supportive, sisterhood, empowering, reassuring, valuable, companionship. These are all positive, very tangible words that they provided. 4 out of the 38 patient responses, or 10.5%, to the qualitative question did not claim to receive any support from attending the group sessions because of finding their diagnosis harder to discuss with strangers and experiencing increased stress after listening to other patients' testimonials. Key facilitators for this study were the heart team and statistician. There were no significant barriers to study implementation. Unintended consequences of the study were positive and negative. The positive was the study response rate was really good at 39.4%. There was an even distribution of respondents in each group, and all attendees of the 10+ groups reported that they were very satisfied with attending the group and their treatment decisions. The negative unintended consequence was there was one really extremely negative open-ended comment that said that the breast cancer support group was the worst experience she had during her cancer experience. So that was pretty extreme and definitely not expected. Study implications include that the study increases the knowledge of nurses and other interdisciplinary care providers about how frequent attendance of a breast cancer support group can assist patients in making informed and satisfying treatment decisions. The study highlights the opportunity for oncology nurses to hold the role as a support group facilitator and a patient advocate. The study highlights the value that a breast cancer support group affords those women who choose to come. And the study may be used as an exemplar for other institutions when evaluating how to improve survivorship care for their patients with cancer, hopefully including my own institution. The study sample was limited in size and diversity. Some patients had made treatment decisions before they actually attended the group. Some patients were challenged by taking an online survey. And some patients may have been affected by recall bias and not been able to really tell or remember how many groups they had actually attended. So in conclusion, patients diagnosed with breast cancer need to obtain satisfying information about treatment decision-making and receive support throughout their cancer journey. This study demonstrates that women who have more frequent attendance at a breast cancer support group can gain support in making satisfying treatment decisions. Further research can include investigating if support group attendance is more beneficial to patients in different phases of their illness, as well as investigating the benefits of women who continue to come to a support group, investigating the benefits of women who continue coming to a support group get out of supporting others with a new diagnosis. I thank you for listening to this presentation and look forward to actually giving it in person on the 14th and seeing you in person, and I hope you have a great evening, and I look forward to getting feedback. Thanks a lot.